Hello, and thank you for inviting me to be part of this year's annual virtual summer seminar. My name is William Orr, and I am an assistant professor and pediatric cardiologist at Washington University. Today I'm going to discuss COVID-19 and the pediatric heart and how kids can return to play safely. I apologize that my portion is pre-recorded and I will not be available for questions live, but I have left my contact information at the end of this lecture, so please feel free to reach out to me with any questions or comments. I have no financial disclosures. The objectives for this part of the seminar, I was hoping to summarize the cardiac manifestations from COVID-19 and MISE, to identify the definition of myocarditis and how it is related to sudden cardiac arrest and sudden cardiac death, to summarize how to assess a patient who is returning to play and when to refer to their primary clinician or physician or possibly even a specialist such as a pediatric cardiologist, to describe the current utility of cardiac MRI in COVID or MISC patients, and to consider the current literature and management of long COVID and post-vaccination myocarditis. I don't think I need to spend any time reviewing what COVID-19 is, but I wanted to spend a brief part of this talk reviewing MISC. So MISC stands for Multi-System Inflammatory Syndrome in Children and is a post-SARS-CoV-2 related systemic inflammatory illness. You may find a few slightly different case definitions, but the CDC defines it as an individual less than 21 years of age presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multi-system, so 2 or more organ involvement. They also have to have no alternative plausible diagnosis and a positive for a current or recent SARS-CoV-2 infection, either by a PCR, maybe a confirmed COVID-19 case within the last 4 weeks prior to the onset of symptoms, or they could have even been around somebody who was positive. They do include some examples of lab evidence of inflammation, and the organ involvement can really be anything from cardiac to renal, respiratory, hematologic, gastrointestinal, dermatologic, or neurological. One thing that I know a lot of these studies that are currently happening are trying to do is to get some lab data, some immunologic evidence that would help better define this case definition. So this may not be the case definition in the future, but currently is what and is how we are diagnosing patients with MISC. MISC typically occurs between 2 to 6 weeks after an initial COVID-19 or SARS-CoV-2 infection. This is a graph that is already starting to become somewhat outdated from a somewhat recent publication from the CDC regarding geographic and temporal distribution of children with MISC. As you can see from this graph that there are 3 peaks for MISC. The first 2 peaks follow the peaks for COVID-19 by roughly 2 to 5 weeks. And the third peak seems to follow the rise in COVID-19 pandemic that was back in November. So the gray area towards the right of the graph represents at the time of publication, which was the most recent 6 weeks of data at the time. Now, I would imagine that given the current kind of surge going on right now and the increase that we're seeing in our hospitals in our region, if this figure may look a little bit differently if this was published today. We may see another hump. The incidence of MISC was 2.1 nationally and varied from 0.2 to 6.3 among the reporting states. The burden of MISC in each state was generally highest in the Northeast, while the West and the Midwest states had the high burdens of pediatric COVID-19 cases. This figure was just copied from the CDC website, where you can actually compare trends across states and regions. You could only choose 6 states to compare at a time, and I chose states which I would consider a drivable distance for teams to travel for tournaments or competitions, and anyone can go in on their own and pick the states they want to look at and look at these trends. And what this does is it graphs the number of cases over time using a 7-day average, rolling average of new cases. The most useful thing about this graph is not the big hump we had kind of in the middle, but towards the right of the graph, what's happening currently, and you can see that the number of new cases is actually starting to increase again. And unfortunately for us, more so in Missouri than the surrounding states. I think the takeaway probably from this graph, unfortunately, is that the COVID numbers are increasing. Maybe it has something to do with the variants that we're seeing out there. And it's unfortunately crucial for us to remain vigilant when we are assessing our athletes and looking at our athletes and they're coming back after being sick, or maybe even after the summer break and school starts to get in session again, is that knowing that this is still very much a thing to pay attention to. As a transition into our next topic, I wanted to start with a question. So cardiac manifestations from COVID-19 and or MISE include which of the following? A, atrial and or ventricular arrhythmias. B, systolic and or diastolic dysfunction. C, pericardial effusion. D, dilated coronary arteries. E, heart failure or cardiogenic shock. Or F, all the above. I'll just give a few more seconds. And if you're following along and you said F, then you would be correct. I apologize for how busy these next few slides are, but I wanted everyone to see how differently these patients can present. So the table on the left reports signs and symptoms and clinical findings among patients with MISE. These patients, whether or not they had preceding COVID-like illness, most frequently presented with GI symptoms, including abdominal pain, vomiting, diarrhea. There also may be a high percentage of cardiac manifestations, which raise the most caution when determining the level of activity a child can participate. The most common cardiac manifestations was cardiac dysfunction at roughly 24 to 34%, but there was also a high percentage of patients with myocarditis, coronary artery dilation, and pericardial effusion. Now the table on the right from a different paper focuses more on the clinical, laboratory, and echo findings among MISE patients, and this showed that 68 to 95% of patients will have elevated troponin, and 78 to 100% will have an elevated BNP or proBNP. The incidence of cardiac dysfunction and coronary artery abnormalities between these two studies are very similar, and when comparing this data actually to our own institutional data, which I would argue is kind of a regional representation, is also very similar. The same cardiac manifestations can be seen in patients with severe acute COVID-19 infections. I think before I get into this, one important thing is with these new variants, are we going to see as sick of patients? I don't know if we know that yet. We are definitely seeing patients getting sick, so I would think that even though that this is not the first round of COVID patients, I would still consider all of these manifestations, these cardiac manifestations, as a possibility. So these two illustrations have similar messages that the cardiac injury is likely multifactorial, which can be from high levels of circulating cytokines, microvascular dysfunction, direct viral invasion of the cardiomyocytes. You could have ischemic injury, hypotension, arrhythmias, and pre-existing cardiovascular disease. Specifically looking at coronary changes, which on the last slide was reported at about 8 to 24% of patients, the pathologic mechanism of this is not confirmed yet, but it's thought to be related to inflammatory mediators causing inflammation and disruption of the arterial wall. So this is a fundamental unanswered question as to who and why some children will be affected and while some others won't. The immunologic and even genetic profiles of these patients are actually being studied and hopefully in the future will be better answered. And depending on which cardiac manifestations patients develop does play a major factor in long-term management recommendations and even activity restrictions, which we are going to get into. And so the big question is, I've been through all of this data and these labs, etc., but how does this relate to our athletes and what are we going to actually see on the field or in the gym? And I think the biggest question is, how will our athletes present, and what are the things that should throw up a red flag for you and your coaches? Because quite honestly, everyone listening to this lecture, along with the coaches and the schools, are honestly going to be probably first line for picking up some of these symptoms. And so an athlete may be completely asymptomatic. They may be the most difficult. They may never have any symptoms, they may be totally fine, which would be great. They could be symptomatic until they have something catastrophic happen. We have not really seen any of that, so hopefully, people don't get too worried about that. The athlete may just have some exercise intolerance. There is I think, an underappreciated degree of how much deconditioning has happened while somebody gets COVID-19, and definitely over this past year while everybody's been on quarantine or is now starting to come back into physical activity and being part of sports teams again. I think the caliber of an athlete, they mentally think they should be back at, where they left off, but quite frankly, they have a long way to go. So is it exercise intolerance from just deconditioning, or exercise intolerance from actual, leftover virus symptoms, which we'll get into long hauler and long COVID symptoms? They may have shortness of breath. The virus can leave, some lung injury that may take some time to resolve, so they may get more short of breath or may have more dyspnea on exertion. They could have chest pain, which is very challenging to tease out, because typically if you remove COVID-19 from an MISC from the picture altogether, chest pain in an otherwise healthy individual is very rarely caused from a cardiac etiology. Most of the time it's actually caused from musculoskeletal, maybe GI, idiopathic, and so very rarely is it actually something cardiac or from some cardiac ischemia. But now, given the cardiac manifestations we've seen with COVID-19 and MISC, and the fact that they could have myocarditis, it does make it more challenging, because it may actually be something from their heart. And so teasing that out may be difficult, and may require some level of extra imaging or maybe extra labs. And so that one may be really hard, but it's the chest pain is going to be tough. Palpitations may also be tough. Palpitations, with myocarditis, which we'll get into shortly, you can have arrhythmias if you have scarring from the inflamed muscle. You can have palpitations, which may be just a sensation that the patient or the athlete is reporting. It may be totally benign and actually nothing, and just maybe a little bit of anxiety, or it actually could be something very concerning. They could have syncope or presyncope. So obviously collapse during play or during warm-up or exercise is always concerning. And then the worst is sudden cardiac arrest or sudden cardiac death. And I think the thing that everyone has been very worried about is that we know that COVID-19 and MISC can cause myocarditis. And as mentioned before, myocarditis is a frequent manifestation in roughly 17 to 20% of patients who develop MISC. And so I think it's important to kind of review myocarditis, why it's important, not just related to COVID-19, but also with any other time a patient or athlete of yours says that they've been diagnosed with myocarditis and they can't exercise for X amount of months. It may be important to kind of understand why and where those recommendations came from. So another question going into myocarditis is, what is the percentage of sudden cardiac death among people between 0 and 35 years old due to myocarditis? I'll give everybody a second to come up with their own answer to themselves. And the answer is 6%. So myocarditis is not the most common cause of death. It does lead to an increased risk of sudden cardiac death among athletes between 0 and 35 years old. The most common is hypertrophic cardiomyopathy or left ventricular hypertrophy. But myocarditis does put patients at a higher risk than the general population. Now, this is just in the United States. If you were to look at athletes in, say, Italy, the Italians, their number one cause of sudden cardiac death is actually from an arrhythmia. And so they, for example, as part of their screening for all sports before returning to play, before the school year, especially in their competitive athletes, they actually require and ECG or an EKG. This is not something that everyone in the United States, and by everyone I mean, pediatric cardiologists or the people that are kind of sitting on these important boards and meetings. There's definitely not a unanimous decision or idea of whether or not an ECG should be utilized, because it may actually be falsely reassuring. So depending on where you work or kind of what region or kind of what teams you're associated with, you may find that there are maybe some universities, some colleges that do more ECGs. Probably unlikely the case in high school or middle or elementary school sports, but this may be different depending on where you're from or where you may work in the future. So going back to myocarditis, the incidence of sudden cardiac death in this age group is about 2.28 per 100,000 person years, and does have a slight male predominance of 1.7 to 2 per 1. The overall incidence of sudden cardiac death among pediatric patients remains low, but of course when it happens, it does cause and draw a lot of media attention. And if you look among the pediatric population, sudden cardiac death among patients less than 12 years old is mostly anecdotal. Now this factor, the fact that below 12 is so rare, did play a role in some of the return to play algorithms that were published earlier on, which we will go over. But before getting into any of those algorithms, by definition, myocarditis is an inflammatory myocardial disease diagnosed by a combination of histologic, immunologic, and histochemical criteria. This is not something that really can be diagnosed just from taking a history or symptoms that an athlete may complain of. This really does require, maybe some advanced imaging with an MRI or an echocardiogram, and then also likely changes on an ECG as well as some lab evidence. And most commonly in the pediatric population, myocarditis is caused by viruses. And luckily, majority of the time, I would say, heals without issues. And that's, I would like to say, is definitely the case that I have seen in the COVID-19 myocarditis patients. It can, though, lead to very severe myocardial injury that may result in either cardiomyopathy or scarring, which could lead to life-threatening arrhythmias and sudden cardiac arrest. Myocarditis as a manifestation in both acute COVID-19 and MIS-C has been reported, but for different reasons, which I think is important to talk about, but I'm not sure of the clinical significance yet. SARS-CoV-2 virus has been identified in the cardiomyocytes via endomyocardial biopsy and electron microscopy, and you can go back and actually find case reports. This one was published back in April of 2020, where they actually identified the virus itself within a biopsy sample. Diagnosing a patient with myocarditis is not always the most straightforward, and sometimes is somewhat controversial. For example, this past January, there was a study that looked at COVID-related myocarditis literature and some of their own personal autopsy data, which was in adult patients. And what they found and what they published on was that there was very little evidence supporting the direct destruction of cardiomyocytes through the occurrence of virus-mediated lysis, resulting in injury and dysfunction. So they proposed the idea that this hyperactivation of the immune system leading to this cytokine storm caused microvascular and macrovascular thrombi, which may contribute to vascular occlusion and death. All this to say, I think there are maybe multiple reasons, and as I mentioned before, multifactorial causes of cardiac injury and cardiac manifestations. But for the time being, I think for the patients and for the athlete's safety, we have to treat them as if they have myocarditis before letting them to return to play. So not just so everyone knows kind of what happens maybe in the hospital or when they see us in clinic or they get admitted, not every single patient that has elevated troponin or BNP or findings of maybe systolic dysfunction on an echocardiogram is going to get an endomyocardial biopsy. And to get an endomyocardial biopsy, they actually have to go into the cath lab and they have to get biopsies with catheters from inside the heart itself. So more commonly, we'll actually use MRI criteria, something called the Lake-Louise criteria, which if you look up any of these papers or these big articles, they'll talk about the Lake-Louise criteria to assist in the diagnosis. There are some purists out there, especially related to COVID, that have issues with using the term myocarditis without a biopsy. And I think one topic that is probably heavily debated and you've probably heard of or discussed is whether or not a cardiac MRI is a good screening tool among our athletes. This is definitely something that some universities or professional teams who have unlimited budgets, more or less, to screen their athletes, and their athletes are such a major investment in their program that they need to make sure they're safe. They may actually be doing screening MRIs on all of their athletes before they return to play, if they have any symptoms or if they've tested positive. But quite frankly, that's just not realistic for the high school level or lower. So, we have to be somewhat more selective on who we actually send for this test, which is already difficult to get in certain areas and may also be fairly expensive. And I want to go through some of the bigger papers that have been published, and maybe some more recent ones have been published, but especially some of the papers that talk about cardiac MRI and the use of cardiac MRI for screening for athletes. So one of the earliest ones that was published was a research letter back in September of 2020 from Ohio State University looking at their cardiac MR in competitive athletes who recovered from COVID-19. Within the cohort of patients studied, there was no ECG, echocardiogram, or troponin levels suggestive of myocarditis, and the MRIs were performed between 11 and 53 days after a positive COVID test. And they had 26 patients, and out of the 26 athletes studied, 4 of them had cardiac MR findings suggestive of myocarditis, while an additional 8 additional athletes exhibited findings suggestive for prior myocardial injury. So they actually, in this letter, research letter, article, what have you, they went as far to say that a cardiac MR may provide an excellent risk stratification assessment. So this somewhat kind of stirred the pot, and somewhat contradictive to that was an article that came out after that, out of the University of Wisconsin, maybe a couple months later, where they also looked at their competitive athletes. They had more athletes in their cohort. They had 145 cardiac MRIs performed in patients that had no more than moderate symptoms. Their MRIs were performed between 11 and 194 days after a positive test. And in their cohort, they found only 2 patients with findings consistent with myocarditis and concluded that the utility of cardiac MR as a screening tool for myocarditis, especially in patients that have no or mild or even moderate symptoms, is questionable. On top of all that, there have been some interesting studies comparing MRIs in elite athletes and young adults compared to COVID positive patients. One published last July, now, a year ago, looked at 3 groups. So they had a group of athletes with COVID. So they had 59 athletes with COVID. They had 60 athletes without COVID. These were their athletic controls. And they had 27 non-athletes without COVID, which they called their healthy controls. And what they found was that the athletes who did not have COVID had similar findings on their cardiac MRI to athletes who did have COVID, raising the question to the possibility of overcalling myocarditis in what otherwise may just be normal athletic changes, which we've never really looked into before. So while MRIs are probably not the best screening tool for athletes, it may be still used in some instances for returning to competitive play, and I'll get into where some of those may be helpful. So I like to think that because of those two articles from Ohio State and University of Wisconsin, that there were some background interesting discussions and ideas, and they probably decided to pool bigger data and publish something that had more universities involved. And so as of May of 2021, the Big Ten Conference actually put out a study. And so what they did was in September of 2020, the Big Ten Conference mandated advanced testing for all athletes after a COVID-19 infection before they could return to play. This included electrocardiograms, ECGs or EKGs for short, echocardiograms, serum troponin levels, and cardiac MR. 13 of the 14 Big Ten universities agreed to participate. It went from March 1st to December 15th. It was a survey study, and they had 9,255 athletes who underwent COVID-19 testing, and of those, 2,810, so 34.4%, had tested positive. And the prevalence of myocarditis after all of that was only 2.3%. And so I've spent a lot of time talking about myocarditis and defining myocarditis and how it may be related to COVID-19, but maybe that doesn't necessarily translate into our athletes or clinically, or what it means for an athlete, or maybe if a coach comes and talks about how their athlete can't return to play and they don't understand why. So this may be more helpful to understand where the guidelines come from, or what the guidelines actually say, and why, and what they have to have done before they can go back to playing. And as you'll look through the current literature, you'll notice that most, if not all, of the return to play guidelines actually refer to, their most severe patients. They'll say, follow the current myocarditis guidelines, etc. And so the current class 1 myocarditis guidelines recommend that before returning to competitive sports, athletes should undergo no less than 3 to 6 months after an initial illness, which is a long time for an athlete who maybe their senior year, maybe they're going to go up on scholarship. This is probably the least favorite part of my job, where you have to kind of, in a sense, crush a kid's dreams. The testing before they return to play includes an echocardiogram, a 24-hour Holter monitor. A Holter monitor is just a 24-hour monitor they wear, and it records their rhythm for 24 hours, so that way we can see if there's any abnormal heartbeats or extra heartbeats or any arrhythmias that are concerning. And then an exercise ECG, known as an exercise stress test. The quote at the end, I think, is important, and it says, "At present, it is unresolved whether resolution of myocarditis related late gadolinium enhancement should be required to permit return to competitive sports." That late gadolinium enhancement, that's something you find on MRI. So basically what this is saying is, at this time, it's not 100% agreed upon whether or not you need a cardiac MRI before you can return to play. I would say the general trend in myocarditis, especially at larger institutions that have access to cardiac MRI, is to actually get an MRI. But if you go to some of these more rural places, or places where there's not large pediatric institutions, they may not have the ability to do pediatric cardiac MRI, and so they may not include that, which is totally fine. And they have to use their other testing that they have to kind of make that decision. So using all of that working knowledge, let's look at some of these algorithms and kind of where they've come from and what we actually have to kind of follow. But before doing that, let's do another question just to kind of internally gauge where you would be if somebody were to ask you. So you have a 14-year-old soccer player who tested positive for COVID-19 15 days ago. Symptoms included myalgias, fatigue, loss of smell and taste, slight non-productive cough, and 3 days of fever. Symptoms lasted for 5 days and now is completely back to baseline. The patient did not participate in sports, but now they want to rejoin practice. So would you allow the patient to return to play with gradual resumption of activity, which we'll talk about, or would you refer them for additional cardiology evaluation? And this one's somewhat hard. So I said to return to play, but in reality, it may be a good idea to have this patient talk to their pediatrician. Now, I'll go through the most current recommendations. It actually doesn't require necessarily this patient to be seen physically by their pediatrician, but it is likely a good idea just to make sure they've kind of had that discussion and talked about it. So if you had said either one, I don't know if you would be wrong. Now let's look at where some of these algorithms and some of these return to play recommendations originally came from and where we've come from. So the very first set of recommendations were published in May of 2020, and it would be the first of many renditions that would help provide some guidance on how to let athletes return to play. That was mostly written by adult cardiologists and maybe geared towards the adult athlete. And roughly 2 months later, in July, so roughly a year ago, a similarly organized algorithm came out geared more towards pediatric patients, which is on the right-hand side of the screen. And I say similarly organized because you can see that right away there's three main branching points, is the asymptomatic or mildly symptomatic patients, the more moderate that weren't hospitalized, and then the last column or the third branch is the significant or hospitalized patients, or the ones that were diagnosed with myocarditis. One of the biggest differences right away that you would notice, and that we noticed, was that the pediatric version advocated for less extensive cardiac testing for patients compared to the adults. And that's not necessarily because it's less important, but because statistically speaking, kids have a lower chance of sudden cardiac arrest and death compared to adults, which I showed in our previous, graphs and plots. And the pediatric algorithm was actually divided into three branches, as I mentioned, the asymptomatic and mild symptoms, the moderate symptoms, and severe symptoms. The asymptomatic mild symptoms were patients that had no fever and less than 3 days of symptoms. They were cleared to go back almost immediately. Looking at the opposite end, were the severe or hospitalized patients. They would follow the myocarditis return to play algorithm. And the middle branch, which is the moderate branch, and I've always thought to be the most challenging, they decided to actually break that into two categories, being less than 12 years and older than 12 years. And that is because, as I mentioned before, that sudden cardiac death in athletes is below the age of 12 is extremely rare and mostly anecdotal. You'll find some case reports out there, but it is extremely uncommon. So doing crazy extensive testing and for these patients, may be overkill. And so because they knew that statistics, they actually broke the moderate category kind of down into two different ones. They did say that patients greater than 12 years of age, that maybe at an age involved in higher intensity sports, they should have an ECG added to their screening. And if it's normal, they could go back. And if it's abnormal, maybe they should be referred to a pediatric cardiologist. Maybe they should have extra testing. And if any of that testing is abnormal, then they kind of fall into that severe category and they should follow the myocarditis guidelines. This past March, a leadership article out of the American College of Cardiology summarized most of what I've gone through already, along with an adapted algorithm, and highlighted a number of topics that would need to be addressed in maybe some of these upcoming registries that are being collected and studied, including the use of cardiac MR, following the myocarditis guidelines, whether or not that's what we should be doing, wearable mobile technology and long-term prognosis. And the algorithm that they published was a little less rigid than previous renditions. And I think that's an important concept, is if you look at the very first set of algorithms, these were all algorithms recommendations based on zero data. We had just kind of shut down as a country. People were trying to figure out how to resume sports safely, and they were really just using their best judgment to kind of get people back to sports safely. But they definitely erred on the side of caution because of the multiple unknowns. And over time, I'll show you, I've been showing you, and that you'll see is that they've kind of all gotten a little less rigid and lightened up a little bit. And this one, which was published in March, so now almost a year from the very original ones, they looked at the asymptomatic and mildly symptomatic column, and they recommended cardiac testing only on an individual basis. But in the moderate symptoms, they still recommended extra testing with an ECG and what they considered the triad. And they also recommended no exercise for 10 days from a positive test and or resolution of symptoms, which this actually, if you recall, used to be 14 days actually from resolution of symptoms before they could be cleared to go back to play. This is all since somewhat lightened up, which is good and probably great for our athletes, and also good to know, I think, for anybody who's working with athletes. And ironically, that leadership article, was listing all these things that needed to still be answered. And ironically, a month later, this article came out in Circulation, which is a high impact factor cardiology journal that maybe answered some of these questions. And it was regarding SARS-CoV-2 and cardiac involvement in young competitive athletes. This is probably, to my knowledge, one of the largest multiple institution studies looking at young athletes. And they gathered a little over 19,000 collegiate athletes from over 42 colleges and universities from September 1st to December 31st of 2020. A little more than 3,000 tested positive for SARS-CoV-2 infection with a mean age of 20. The primary aim was to determine the prevalence of cardiac involvement in collegiate athletes, and the secondary aims were to assess the diagnostic yield of cardiac testing and identify risk factors for cardiac involvement and determine the prevalence of adverse cardiac events. And so of the 3,018 athletes who tested positive for SARS-CoV-2, the prevalence of myocardial involvement was only found in 21 of the athletes, so only 0.7%. They do spend time in the article defining what definitive, probable, and possible SARS-CoV-2 cardiac injury mean in their paper. Patients had a cardiac MRI either from an abnormal triad of testing, or if it was a protocolized requirement to get a cardiac MR if they had cardiac symptoms. So triad testing is what they called the three test of getting a 12-lead ECG, an echocardiogram, and then a troponin level. As I said, the mean age was 20 in both the total cohort and of the patients that had myocardial involvement. 32% of the total cohort were female, and 48 were female among the athletes that had myocardial involvement. Roughly 48 of the patients had myocardial involvement were white, non-Hispanic. 38% were black, and the remaining 14% were white Hispanic. Picking out a couple interesting points, there were no adverse cardiac events with a median follow-up period of 130 days in the athletes with cardiac involvement. And among the entire cohort of SARS-CoV-2 positive athletes, there was one adverse cardiac event, which was a successfully resuscitated cardiac arrest. And because this athlete underwent a cardiac MR following their SARS-CoV-2 infection and was negative and they had no cardiac involvement, they felt that this aborted sudden cardiac death or sudden cardiac arrest was unrelated to SARS-CoV-2. Of the total cohort, 10 athletes were hospitalized or treated in an emergency department for non-cardiac complications. such as a submassive pulmonary embolism, a symptomatic large pleural effusion. Maybe they had some desquamations on their hands due to, a mild multi-system inflammatory syndrome. But overall, the incidence of cardiac events was extremely low and potentially even none. And so I think that piece of information should be somewhat reassuring. I mean, it should make everyone feel reassured that it's not a high likelihood that one of their athletes is going to have a cardiac event and they're going to be at the school, or they're going to have the athlete that collapses and dies because of COVID-19. I mean, realistically, let's take a step back and look at how many patients, how many kids, how many adults have been diagnosed with COVID, and then there's however many more that never actually got tested who probably have it. And we haven't seen just a ton of people dropping dead while playing sports or on the field or on the basketball court or wherever. So that should be reassuring. Now, I'm not saying that because I think everyone needs to just say, oh, you're fine, you don't have to worry about it. But maybe that can make everybody sleep a little bit easier. I still think any athlete that complains of a symptom or is not quite doing okay when they come back should definitely be evaluated. But maybe that piece of information will make you sleep a little bit better. And so given, going back to this paper, given that low prevalence of cardiac involvement and the absence of adverse events during at least the short-term surveillance, they recommended making some changes for future return to play. And the first one was that athletes with asymptomatic or mild symptoms do not require additional cardiac testing. The second was that triad testing in the form of an ECG, troponin levels, and an echocardiogram should be considered among athletes with an acute infection who experience moderate symptoms or cardiopulmonary symptoms. And then finally, the diagnostic yield of a cardiac MRI would be optimized if you only use a cardiac MRI in athletes who have a high pretest probability and of acquired myocardial pathology. So patients that are complaining of cardiopulmonary symptoms or do have abnormalities on their triad testing. And so this is, if I'm going to send, anybody to maybe one place to kind of get the most updated recommendations, it's probably going to be the American Academy of Pediatrics. And so, their whole task is to kind of follow this literature. It's kind of hard for one person to be following all this data and to kind of understand it and see what the recommendations are. And so I would send anybody kind of to the American Academy of Pediatrics. It's sometimes somewhat delayed, and it's updated maybe every 3 months or so, maybe once a quarter, but they keep it updated, and definitely as I've been following this, I've noticed that it's become a little less strenuous. And so the most recent ones update was back at the beginning of June. I think June 4th of this year was the most recent updates. And this is important because this is where, you'll be able to help guide which patients need to be seen, which ones can maybe return to play. But what they said was that asymptomatic or mildly symptomatic patients, and they define that, is less than 4 days of fever and less than a week of myalgias, chills, and lethargy. They don't actually, their recommendations are not even necessarily to be seen in the office. But they do recommend at a minimum that they should give their pediatrician a phone call, maybe set up a telemedicine visit, just to kind of run it by them to make sure it's okay. This is different. At the beginning of all this, a year ago, the recommendations was that every single patient who tested positive should have an evaluation and an exam. So this is a big change. Moderate patients, so patients that have had symptoms of fever over more or equal to 4 days, a week or more of myalgias, chills, or lethargy, or maybe were hospitalized without evidence of MIS-C, they should not return until they have symptom resolution, and they should be evaluated by their by their physician or clinician. The clinician should focus on kind of their the AHA 14 element screening evaluation, which I'll go over next. And then they should have a complete physical exam, and they're still actually recommending an ECG. The severe patients, maybe the ones that required an ICU stay, maybe the ones that were intubated, or if they were diagnosed with MIS-C, those should continue to follow the current myocarditis pathway and should be restricted, for the minimum 3 to 6 months, while also being seen by cardiology. And this next bullet, I think, is another very big change. So they said for children and adolescents with a history of SARS-CoV-2 infection who have already advanced back to sports on their own and do not have any abnormal signs or symptoms, no further workup is necessary. So I don't know how I feel about this one. I like the fact that, a year ago, 6 months ago, maybe even less, we were saying, and we were maybe advocating that anybody who had a positive test within the last 6 months should be evaluated by their, pediatrician or clinician before coming back to sports. But that was probably a little overkill. And so if a patient has already gone back and they're doing totally fine, there's probably very little utility on being evaluated. That is what I'm hoping people don't take away from this, is that they, an athlete or their parents or a coach or anybody says, go back to play, ignore that, and then if you have signs or symptoms, then you can go and get evaluated. Because I don't know if that's the best approach, but if it's, if somebody comes back and they're playing, starting their fall sports and they said, yeah, I had COVID at the beginning of summer and I've been playing and doing okay, I think that athlete is fine to go back without being seen by their pediatrician or by a cardiologist. They still definitely promote the idea that if an athlete does go back to playing sports and there are symptoms, then they should probably stop and be evaluated before going back. Now, I had mentioned in the last slide the AHA, or the American Heart Association 14 element screening tool. And this is a screening tool that is recommended to be used for all screening to go back to sports and not specifically for COVID-19. And when you think about the COVID-19 patients, this is a little broad and not specific to COVID. But some of the things to highlight is the personal history. So is there exertional chest pain or discomfort? Is there exertional syncope or near syncope? Do they have excessive exertional and unexplained fatigue? They may have had a history of a murmur, but again, that's not necessarily related strictly to COVID. Some of these other ones that are not related is if they have like Marfan's type body habitus. And so, definitely looking at all of these is that, some of these histories, personal histories, as they go back to play. And when an athlete is finally cleared to return to play, the recommendations still stand that they follow a kind of 7-day, 5-stage kind of progression back into play. And you'll find these everywhere. You can find this on the AAP website. These have been adapted from, or these in particular have been adapted from an article from the British Journal of Sports Medicine. They're very similar to some of the concussion return to play. And this is something that actually may be something you're heavily involved in with athletes after they've been cleared. And everyone listening to this may be very familiar with what these are, but stage 1, which has 2 days in it and has a 2-day minimum, basically is 15 minutes or less. It's light activity. The intensity is very mild with no greater than 70% of the maximum heart rate. Should have no resistance training. If they progress through these 2 days in this stage without symptoms, they can go on to the next one. And at that point, you can do 30 minutes or less. You can add simple movements. The intensity is no greater than 80% of the maximum heart rate. Stage 3, now 45 minutes. You can have more complex training. The intensity again, should be no greater than 80%, may add light resistance. By stage 4, which is, they include 2 days, so day 5 and day 6, an hour of training with normal training activity. Again, they say the intensity no greater than 80% maximum heart rate. And if, again, no symptoms, they can go to day 7 and return to full activity and participate in competitions, tournaments, what have you. I think if any athlete has symptoms, they have to stay at that stage until they don't. Or if they can't progress through the stages and they haven't been evaluated, maybe they need to be evaluated, or if they have been evaluated, maybe that's a sign that they need to be referred to a specialist. So I wanted to go through a couple examples just to maybe solidify some of what we've talked about. Let's say you have a 10-year-old female or male who had COVID positive and had moderate symptoms, so fever for 4 days, cough, shortness of breath, chest tightness. They're now back to baseline after 20 days. What would you do? And because this patient had moderate symptoms, the recommendations are actually to have them being seen by their family doctor or their pediatrician, and have a physical exam, maybe do that screening tool, and maybe even do an ECG. And part of that is because they haven't returned to play. Now, if this athlete said they had moderate symptoms and this was, again, the beginning of the summer, and now they've been back to play and they've done club or rec sports and they've been totally fine, maybe that's a different story. Maybe you just watch them as they are playing, and if they have any new symptoms, then you send them in. So let's say you have a 16-year-old who has COVID positive and had mild symptoms, and upon returning to play develops easy fatigability and can't perform at the pre-COVID level. What would you do in this situation? And this one I don't know if I have a great answer for. I think if you think that these are symptoms related to COVID-19, and maybe there's some shortness of breath related to it, maybe some chest pain, it'd probably be on the safe side to send this patient in or this athlete in for evaluation. If you think it's just because of deconditioning and it's actually been multiple months since their COVID and they're having issues, it may just be deconditioning, and some of this is hard to tease out. And like I said before, athletic trainers, coaches, you guys are all on the kind of first line, and it's especially for a specialist like myself. I mean, they may even see a pediatrician first, so they're the ones that I'm seeing are the ones that have really abnormal findings or concerning symptoms. So my job actually may be somewhat easier than what everyone else is having to deal with. But it does bring us into this long COVID symptoms or illness that we're seeing and dealing with now, that we've had more patients kind of get COVID. Sometimes you'll hear this referred to as post-COVID, or the patients themselves as long haulers, and it's kind of this 4+ weeks after an infection of these lingering symptoms: fatigue, palpitations, autonomic dysfunction. They may have headache, shortness of breath. I've had a few patients that can't even tolerate walking up the stairs to their classroom. They may have anxiety. The patients can be very heterogeneous, and they may have totally different symptoms. And unfortunately, there is no great treatment. So the treatment may follow some of the kind of chronic fatigue syndrome patients. They may follow some of the POTS patients, where the data out there suggests that doing a graded return to play, maybe even with physical therapy, may be beneficial and actually more superior than any medicines. I've had patients that we've started on beta blockers. I've had patients we've started on other medicines such as Florinef, which is a low-dose steroid, that have had good results from all that. So they're hopefully recovering, but it can actually be fairly debilitating for some of these athletes, and there's no rhyme or reason on which athletes are going to get it or how long it's going to last, and it quite frankly can be rather difficult. And now, on top of that, another issue that we're starting to see is this post-vaccination myocarditis. And what it is an extremely rare adverse event after receiving an mRNA COVID-19 vaccination, such as the Pfizer or the Moderna. And when I say rare, I'm talking about, millions of vaccines given that have been administered, and as of July 12th, there have only been a total of a little over 1,000 reports of this post-vaccination myocarditis. Most of the cases have occurred in male adolescents and more often occur after getting the second dose compared to the first dose, and typically occurs several days after vaccination. I had somebody reach out to me recently asking if a patient had a myocarditis. They had some symptoms of anxiety about 20 minutes after getting the vaccine, and that's not possible. So it's happening a couple days, maybe even 2 days, but not immediately after the vaccination. And most of them, I would say, most of the reports that I've read improve very quickly, and they don't have any residual sequelae. But again, this is another unknown category and an unknown area that, these patients should probably be evaluated. They should probably talk to their physician. It's tough to say whether or not these athletes are all going to be out for 3 to 6 months. That one's tough. I don't know if I have the answer for that one right now. But I can say that of note that the CDC is still recommending the vaccine, and I myself would still recommend the vaccine given that this is an extremely rare event. So in the last few minutes, to wrap up, I wanted to highlight a couple take-home points. The first is that COVID-19 and MIS-C can lead to life-threatening cardiac manifestations. But again, the literature now is that it is rare. So hopefully, we don't have any of our athletes in the area being one that has any newsworthy events. It can be extremely heterogeneous manifestations, which make returning to play and evaluating our athletes difficult and requiring an individualized process. Again, I think it's very reassuring, but don't get too, relaxed with your evaluations and kind of your vigilance that the overall prevalence and adverse cardiac events is low. I think do your best to keep up with the current return to play guidelines. Again, if I'm going to send anybody anywhere, it's going to be to the American Academy of Pediatrics because they'll synthesize all of the data for you. I would say if anything ever seems off or questionable and just not right, I don't think anybody would ever be upset for referring a patient to be evaluated. And then also there's just an importance of an AED accessibility and training. And then lastly, to get vaccinated. I know not everybody has access to AEDs, and if you don't, maybe you could take this back to your school or your institution. We have started, one of my colleagues who has actually secured some funding to start education in some of our local schools here, where they're actually going to go in, provide AEDs and education on how to use them. They have actually paired up with a program that's already out there called Project Adam and Heart Safe Schools. And so what they'll actually do, like I mentioned, is they'll go in, provide the AEDs, make sure they're educated, because we know that the most important, crucial thing to these patients that collapse is early intervention and access to an AED. So if you don't have one of those at your school, it might be something worth talking about to some of the higher ups. And so with that, I want to thank everybody for taking their time to listen. Again, I'm really sorry that I'm not doing this live and can't take questions live, and maybe even do this next year in person or live. I'm happy for you to reach out and give me feedback or ask questions about a certain situation or kind of in general what what you should do to proceed. So I've also listed my references for you to look at if you want to kind of pause the screen and take a look. Thanks.